As you know, the human heart has four chambers. You have the upper chambers that are called the atria, and you have the lower chambers that are called the ventricles, and the upper chambers have a little outpouching called the left atrial appendage. This left atrial appendage is an embryological remnant very similar to that of the appendix in your colon, comes from the fetal stage of human development, and most of the times it really doesn't have much of any significant function. But the left atrial appendage can become problematic in terms of stroke and also a source of arrhythmia when patients develop atrial fibrillation. So, in a normal rhythm, the human heart generates electrical impulses at a rate of 160 to 100 beats per minute from a structure called the sinus node, and these impulses go from there into a junction box, spread around, and makes your heart beat in a normal rhythmic fashion. But when you have atrial fibrillation, your upper chambers fibrillate much faster at a rate of about 400 to 600 beats per minute, thereby making your upper chambers quiver instead of actually contracting. So when your upper chambers are quivering and not really pushing the blood across from the upper to the lower chambers, some of this blood ends up getting trapped inside this little structure called the left atrial appendage. Because it's not contracting appropriately, the blood that is trapped inside that left atrial appendage is now going to naturally gel and form a clot, and this clot really becomes the problem. Over a period of time, this clot can work itself out of this left atrial appendage and go up into your brain and cause a stroke. This is the natural connection between atrial fibrillation, left atrial appendage, and strokes. Several researchers in the past have tried to understand how to prevent clots in the left atrial appendage. Blood thinners have historically proven to be important, and that's the reason why for many decades we use the good old rat poison, which is the warfarin, to take care of patients who have atrial fibrillation and prevent strokes. And then subsequently, the direct oral anticoagulants, 4 different of those new drugs have arrived in the last 10 to 12 years and made it into the marketplace. But all the blood thinners do cause bleeding complications. So how do we really mitigate the need for blood thinners using a minimally invasive approach? So if you think about it theoretically, if there is a way we can eliminate this appendage completely, either by tying it off or ligating it, or if you can put a mechanical barrier across this left atrial appendage so that we can prevent clots that are formed inside the left atrial appendage from coming out, or preventing blood from going in, we can mitigate the risk of clots and subsequently the strokes. This is where the concept of mechanical left atrial appendage occlusion came into being. And several clinical trials and research has been done in this particular space, and we now have access to multiple of these devices, and the Amulet device is one of those good examples. The Amulet has a lobe and a disc. What you see here is the left atrial appendage occluder device called the Amulet. The Amulet has a dual closure mechanism design where you have a lobe that sits inside the body of the left atrial appendage, and it has these tiny little anchors that helps the device to be anchored into the cardiac tissue. And then it has a little neck, and then a disc that is outside of the appendageal ostium that really helps to get a much better closure, accounting for some of the differences in the cardiac anatomies of patients. What you see here is the iteration of the left atrial appendage and a delivery sheet that is trying to help us to bring the device up in here. And then the lobe and the disc actually are compressed and loaded into this delivery sheet. So the doctors that are going to implant this particular device are going to go through your groin, up into your heart, and once they are in the exact position as confirmed by the fluoroscopy or otherwise the X-ray and the transesophageal echo or the ultrasound machine they place inside the patient's esophagus, we are able to visualize what's happening inside the heart. So the lobe is first delivered in an appropriate location, and once the lobe is in place, we will release the disc so that the disc can oppose at the opening of the left atrial appendage. And at this point, you tug it and make sure that the device is appropriately and nicely seated without the risk of mobilization. And once you're happy with what you have here, this little tether that is still attached to the delivery sheath is now going to be removed, and the device is going to be untethered and released. At this juncture, we put a little bit of contrast into the space and making sure that we have good closure, and this is also confirmed by the ultrasound that is there inside the patient's esophagus. We know that the left atrial appendages come in various shapes and sizes, and this is one of the biggest challenges that we have in terms of getting perfect closure. A lot of times you have appendages that are that look like a bird beak. You have appendages that have proximal lobes, really making closure difficult. Sometimes they look like cauliflower or broccoli, and they can also look like chicken wings. So the dual closure mechanism devices like the Amulet, because of their excellent design, this lobe can nicely sit in any part inside the body of the appendage, and then we're able to use this outer disc to get a nice closure at the level of the opening of the left atrial appendage. So as a result of this, the Amulet device conforms much better in different left atrial appendage anatomies.